So now we have another complex problem, and that is Brown syndrome. And that's my colleague from AIMS, Dr. Rohit Saxena, Professor Rohit Saxena, who is going to talk about the Brown syndrome management. Dr. Rohit.
Thank you, sir. Thank you very much for the opportunity to be here and present in your IC. It's always a pleasure. It's always a learning experience just listening to you. So I'll be talking about Brown syndrome. Essentially, well described, was initially called pseudoparesis of the inferior oblique because the primary problem is the inability of the eye to elevate in adduction, and also a superior oblique tendon sheath syndrome because it is the absence of the tendon sheath to lengthen, which does not allow the inability of the eye to elevate in adducted in primary position. It's not a very common, but again not so uncommon also as compared to some of the conditions we've been talking about. Just to demonstrate the condition, this is a patient of a right Brown syndrome. You can see essentially aligned in primary position. There is a small dip when the eye goes into levoversion, and the eye is unable to elevate, adduct and elevate. And normally you would have thought that this is either, if so it was an inferior oblique palsy here, you would have a corresponding superior oblique overaction, which is not a consistent finding. Some may have it, but often they do not. And accordingly, you would have expected that because the IO is underacting, the corresponding SO may be overacting, you should have an A pattern, actually has a V or a Y pattern. So the eye is going up, but suddenly it just switches outwards because it can't go up straight. So this is the classical feature. So there'll be a downshoot in adduction. There is a deficiency in elevation and adduction. There is a limitation of the elevation in primary elevation, but there is no significant elevation deficit in abduction. There is a V or a Y pattern that is there, and the forced duction test is positive. So again, just to demonstrate that, you can see the limitation of elevation here, not so much and virtually aligned in this case, and the divergence in up gaze or a V or a Y pattern. Sometimes, as I mentioned, you may have a superior oblique overaction also present in these conditions, and you'll see the torsion, corresponding torsion in the fundus. It can be congenital or acquired. So most common is a short anterior part of the tendon sheath. It's an inelastic tendon, and also there are tendon trochlear complex problems where the telescoping of the superior oblique as it goes through the trochlea does not happen. So there are congenital additions in the entrance to the trochlea. Of course, there can be any other cause. In an acquired case, there could be inflammation, trauma, the nine-tooth syndrome, or iatrogenic, like we can do it, excessive tucking in case of a superior oblique palsy. So when you do an excessive tuck, that's what you're doing. You've tightened the superior oblique so much that it is not able to now relax enough to allow the eye to go up and in when the superior oblique is actually wrapping around the globe and requires its entire length. So it could be mild when essentially there is a restricted elevation in adduction. Along with that, if there is a downshoot in adduction, it becomes a moderate. Along with hypotropia in primary position becomes severe. So depending upon how severe it is, it becomes your indications for surgery. And Brown plus would be an associated superior oblique overaction. Your differential diagnosis could be an inferior oblique palsy, but the difference would be an A pattern, as I mentioned, and a downshoot on the opposite side head tilt. A superior